Welcome to the 2012 lecture for the Iscol Family Program on Leadership Development and Public Service. My name, as it said, is Alan Matthews. I'm the Dean of the College of Human Ecology. And I want to thank all the students and staff that helped make tonight's program happen. But I'm really pleased that Ken and Jill Iscol are here with us today. And so before we move on, I really want to acknowledge both of them for their generosity in making this all happen. So Ken and Jill, please stand so we can. Now you will hear more from Jill as she moderates tonight's discussion with the co-founders of Medic Mobile, two of today's visionaries highlighted in her book, Hearts on Fire, Igniting Idealism into Action. This is truly a wonderful book. I've read it, and it really inspires. Inspires one to think about your own action, but what I loved about the book is that it shows how each person found their own path to making a difference. And I think when you read it, and I hope you do, you will similarly see how possible it is to make change happen, and that so many diverse ways you can use your talents to influence the world. It really is a great book. So congratulations, Jill, on an amazing accomplishment. Yes. Jill and Ken established the Iscol Family Program in order to inspire students to become ambassadors of social change. In that spirit, the program not only funds this lecture, but since its inception in 2007, the program has also supported now over 60 students in public service internships in communities truly throughout the world. This past summer found 18 of our students in communities from North Brooklyn to Tanzania, from Ithaca to India, where they had the opportunity to engage firsthand in addressing some of society's greatest challenges. Jill and Ken's biography is in your program, so I won't repeat all the wonderful work that they have done, but let me remind you of what tremendous supporters they have been to not only this program, but to other university programs as well. And it has been a personal thrill for me over the years to get to know them and to witness their passion for helping students find their passion. Since 2001, the college has been very pleased to house this program. And I see this program as central to the college's mission, which really tries to address significant real-world issues and to use Cornell as a vehicle for combining research, outreach, and undergraduate education, and to bind those seamlessly. And this program does that in a phenomenally effective way. The program not only, again, serves the entire university, so we've been happy also over these last 7 years now to have collaborated with the Entrepreneurship at Cornell program and this class so that more students across the university can benefit from the wonderful speakers the Iscol program has brought to campus. And it has truly been, each year has been great. The college's urban semester program, the Public Service Center of the university, are valued collaborators in identifying students who would benefit from participation in this program. And this year, we worked with the Global Health Program, which sent 5 students to Tanzania and India. What a great combination of organizations that all exist to help provide students with meaningful experiential learning opportunities. So at this time, I would like to introduce John Eckenrode to the podium, who will introduce tonight's speakers. Professor Eckenrode is a professor of human development and director of the newly formed, now, 1 year ago, Bronfenbrenner Center for Translational Research. His work focuses on early interventions for at-risk families, child maltreatment, and stress. From the beginning of the Iscol program, he has worked tirelessly to make this happen. And in our dinner, Jill mentioned when we were thanking her, she thanked John and said basically without John's amazing leadership of this program, it would have never happened. So John, thank you so much for all you've done to make this real. Thanks.
Well, thank you, Alan. I'm going to keep my remarks very brief because I want to save as much time for our speakers as possible. I'm very honored to introduce our speakers again tonight, as I have done for this is our 11th year doing this program. So it's a real tribute to the vision of Jill and Ken Iscol and to their generosity that we can do this every year. And I would like to also thank a couple of people Alan didn't get to thank. There's so many people. But Patty Thayer, my assistant, who's done all of the behind-the-scenes work for this program, and Diana Brinkman, the events coordinator for the college, really put all this together tonight. So I want to thank them especially for all the work that they did. Now, Alan talked about the book, Hearts on Fire, which we'll hear more about tonight. I want to remind you that copies of the book are going to be in the lobby after the talk, where there'll be a reception. Jill will be available to sign copies of the book, so you'll be able to purchase a book if you'd like and have Jill sign it. So I hope you all take a look after our presentations tonight. It's been a great honor for me to work with Jill over the years. We thought tonight we were going to do something a little different. We usually have people come up and give speeches. Tonight we're going to have more of a conversation. We're going to ask Jill to come up and moderate a conversation with our two speakers, Josh Nesbit and Nadim Mahmud, and we'll see how that goes. I'm sure it'll be a wonderful experience for us all. I'm not going to say a lot about Josh and Nadim because you have the biographies in your program, and I also want them to tell their story because part of what they're going to be talking about is how they got to where they're at today. So I don't want to steal their thunder here, but I'll just say that Josh was an undergraduate not too long ago at Stanford in biology. He's now graduated, and he's the CEO of Medic Mobile. Nadim was a Yale undergraduate and met Josh when he was Nadim was a medical student at Stanford, and he's still a medical student and finishing up this year. So he can tell you how he balances being a medical student and running a company. So that's part of the fun. So I wanted to ask at this point for Jill and Nadim and Josh to come up on stage and join me here. I'll pose the first question. Maybe Jill, if she wouldn't mind starting just a very brief reflection on what inspired you to work on Hearts on Fire and engage with such interesting and visionary people like Josh and Nadim.
Well, I'm not going to talk too much about Hearts on Fire, but it's going to be reissued in January by Random House, who bought the rights. And I was inspired to write it because I have had the great privilege of working in the social sector space, some people, the not-for-profit space, for over 20 years. And while doing that, I've been meeting the most extraordinary people who have made my life and my husband's life and my children's lives very, very, very rich just by knowing them. These are people who are using everything they've got to make a difference in the world. But I really want to focus on Josh and Nadim, who I had the privilege of getting to know as I was interviewing for the book. And they have another partner whose name is Isaac Holman, and he could not be here, but the three of them have founded Medic Mobile. And the first question I would like to give a little introduction, which is that Josh and Nadim's story is one which captures the spirit of a generation. It's a story of collaboration. It's a story about technology. It's a story about generosity, integrity, decency, and about their reverence for the dignity of every life on this planet. And from there, I really would like the two of you to tell us about Medic Mobile, how it started, and what you're up to.
Sure. So I'll start. I was an undergrad back in 2007. I went to Stanford to play soccer, and I wanted to be a doctor. Those are two things that I was sure about. I knew that the way I was going to be helpful to the world was to be a physician. And I was slaving away in the chem labs. I figured I should sort of walk the walk in global health, and I had come across these really daunting statistics that 1 billion people will never see a doctor in their lives. I needed to make some sort of sense of that, and ended up working at a hospital in rural Malawi in East Africa, doing pediatric AIDS research. And I met a doctor who was trying to provide care for about 250,000 people. And patients were walking or ox carting up to 100 miles to get to the hospital. So that was the bad news. The good news was I became friends with a community health volunteer named Dixon. And Dixon had this notebook that he kept with him. It was obviously really important to him. He was coming to the hospital and walking to the hospital once a week, 35 miles from his house, to hand deliver these paper reports about HIV patients at his home village. He was delivering those so that the home-based care officer could initial that he was doing his volunteer work, and so that the patient statuses could be checked on. And I went out with Dixon by bicycle the third week I was there, and I had better cell reception at his house than I did in Palo Alto. And I described that moment as getting picked up off the couch and slapped across the face. And the world had really been redone with mobile coverage. If you look at today, 90% of the world's population is covered by a cell signal. 50% of people in sub-Saharan Africa own a personal cell phone. That'll be 100% in less than 2 years. So basically, I was back at Stanford and figured out a way to get a little bit of funding to put 100 cell phones into a backpack, sort of smiled at customs officers on the flights back to the hospital, and we used $10 cell phones, $7 solar panels, and text messaging to bridge the gaps between these community health workers and this hospital. And in 6 months, they doubled the number of patients they were treating for TB, they were providing emergency response for the first time, and they were saving thousands of hours of travel time. And I got back to Stanford again, and I just wouldn't shut up about community health workers and text messaging. It's all I would talk to anybody about. And then I met Nadim.
Yeah. So I think my narrative, at least the relevant part of my narrative, begins when I was at college at Yale. I'm actually a first-generation citizen, so my parents are both Bangladeshi immigrants, and I grew up in a really small town, and always had this curiosity about sort of the culture that my parents came from. They grew up in a time of warfare, and they witnessed the birth of their country, and I didn't understand any of that. And so I had these ideas of going back to Bangladesh while I was in college just to see what it was like, just to try and understand their background, and in doing so maybe try and understand myself a little bit better. And I ended up working at a cholera treatment institute in Dhaka, in the capital of Bangladesh. And I don't know how familiar you are with Bangladesh. Maybe some of you are very familiar, maybe some less so, but there's an annual monsoon. Happens every year, right on schedule. And on the tail ends, on either end of the monsoon, there is a huge spike in cholera cases. So I was working at this treatment facility, and literally more than 1,000 people were being brought in every day, emaciated, literally on the brink of death with dehydration, that were begging for treatment. And we'd take them as quickly as we could into the emergency ward and stick IVs into each of their limbs and just pump them full of fluids, trying to bring them back to life. And that's where I saw my first, well, I'll call my first patient. That's where I saw my first patient die. And he was, I remember every detail of it as vividly as this moment right now. He was brought in by his 2 children and his wife, and he had come 3 days from the villages for treatment. He had been sick for 4 days, and he looked like a corpse to me. I remember trying to get a peripheral IV into his antecubital vein on his left arm, and he just stopped breathing, and that was it. And we found out from the family that they had traveled 3 days, and yet we knew that there had been a satellite treatment facility deployed no more than 15 minutes from their house, and they just didn't know about it. And that was not an uncommon story. A lot of these patients that were coming in and passing away, they were just unaware. There was this huge communication breakdown between the available resources and the knowledge that the patients had of those resources. And so this was back in 2007. And I didn't know at all how we could address that problem. I knew it was a problem. I knew these were really profound communication gaps. But it wasn't until I went to Stanford and had basically a serendipitous meeting with Josh in line for a Thai cart. Thai food cart. And we started talking about what he was doing in Malawi, and he was talking about the robustness of the cell phone infrastructure in Malawi. And I thought back to Bangladesh, and cell phone penetrance there is unbelievable. It's unreal how many people have cell phones over there. Literally, at this point, practically every family has one. Josh gave you some statistics. There are 6 billion cell phone subscriptions worldwide, and 76% of those are in the developing world. And so I think our task became, given that we have these incredible cavernous gaps in healthcare communication, how do we leverage these cellular networks and this technological explosion in the developing world? How do we leverage it to kind of address that healthcare issue? And that was sort of the basis for what we tried to do. And he was talking about Malawi. My head, I instantly thought about Bangladesh and how potentially we could send SMS messages to these families. And just something as simple as you have a satellite clinic that's been deployed in this region 15 minutes away from your house. Just creating awareness of the resources that are available is something that can be impacted so simply with this technology. And that's kind of how I got my interest. And Josh and I, he was talking, like he said, incessantly about it, but I was happy to listen because it all made sense to me.
So just to underscore, you're an undergraduate at Stanford, and you were in
First
your
year medical
first
school,
year
yeah.
of medical school,
Right.
and you meet on a line to get lunch, right?
Right.
And from that moment, you began a company. Was it called Medic Mobile yet?
It was called all sorts of names. We were Frontline SMS Medic with a colon and an acronym and all. It was everything you could do wrong with the brand. So we're Medic Mobile now, which is great. But if you fast forward just 3 years now, we've expanded. We work in 16 countries, mostly in East and West Africa and South Asia. We're a small team, but a team of 20 full-time staff. And so those days working 10 hours from our dorm rooms, 10 hours a day from our dorm rooms, feels like yesterday, but we've actually grown a lot since.
So in 3 years, you're in 16 countries, you have 20 people working with you. How does that happen? How does it happen? How do you do that? How do you get the employees? You're in medical school, you're still a student.
Yeah.
Describe to the group of Cornell students, like you went from the lunch line to 3 years later, this major, really incredible organization with huge impact.
So I think, yeah, it's mind-blowing just to think back 3 years ago, because you never know what instant in your life or a person that you meet, how they're going to impact you down the road. And meeting Josh at that in line for food, for some excellent pad thai, I might say, it was the beginning of a partnership, of a friendship, of so much more. And there's no way that either of us could have realized the significance of that moment. I think something that's helped us is that we've grown very organically. It's a message, the simplicity of what we try and do and the logic behind it just makes sense, and it's a very appealing message. So people really showed that interest. We had no ambitions of creating an organization. We got together and just discussed potential ways of addressing these problems in the respective countries that we had visited, and people were interested. Funders were interested. Other clinics were interested. And so it grew, step by step, but it always felt like the growth made sense.
So what were some of the problems? Because I know that the early one was just to connect the healthcare workers in rural communities to more major healthcare centers. But what other problems have you been able to address and have impact on?
Yeah, so the three things that we do are we help get people access to care who need it. We help people stay in programs that we know saves lives, and we help improve the quality of healthcare wherever it's delivered. And I'll give two really quick examples. One, looking at access to healthcare, maybe the most intuitive thing you can do with a mobile phone is understand a problem and then mobilize resources to respond to that problem. And a really clear example of this is a project we collaborated on after the earthquake in Haiti in 2010. So 1% of the population was online. About 1% of the population had a fixed landline phone, but fully 75% of people in Haiti had a personal mobile phone. And the White House and mobile operators prioritized the GSM network after the earthquake in January, and text messages were still making it through because it was a store and forward technology. So we worked with the mobile operators and nonprofits across 4 continents to stand up a system where anyone could text their need and their location to that number. We went radio station to radio station, letting people know that this channel was open, and we received 100,000 text messages in the first 10 days after the earthquake. The challenge was all those messages were in Haitian Creole, and all of them had vague references to location. So we then went back online and we recruited 3,000 people from all over the world who were translating, categorizing, and mapping every single one of those messages, typically within a minute of each being received. So that's one example of a project. Why don't you talk about India?
Yeah, sure. India's another great example. The theme is going to be, Jill, that every project is a little bit different. We've had more than 50 projects. We've operated in more than 16 countries, as we've mentioned. And this kind of, we'll get at the question more of the process of innovation. But every single project has been different, and necessarily so, because the context of what the challenge is different in each country, in each community. So what we did, we have a project in India, in Cornell. It's a place in Andhra Pradesh, and the vaccination rates for children at 1 year of life have empirically been in the 60th percentile, which is not very good. We tried to roll out an intervention, and the way we did this, we had a lot of interviews and discussions with the health workers as well as patients in this community to understand why that was the case. These vaccinations are supposed to be provided for free through the government with World Health Organization support. So why is it that they only have 60% coverage rates at 1 year of life? And there is multifactorial. A lot of the mothers or caretakers, they forget that multiple doses are necessary. They don't understand necessarily the importance of having multiple doses. Sometimes they forget. They don't know when a satellite clinic is going to be in their community or what day it's going to happen when they can bring their child in for vaccination. Myriad reasons. What we ended up rolling out was a system where health workers enrolled newly pregnant women. They enrolled them in a system via SMS where they would just input, the mother's name as well as their contact cell phone number. And when the baby was born, the system was updated with the child's date of birth. And so based on the date of birth, and we know what the vaccination schedule should be for a child based off of the World Health Organization regimen, our system, our software automated SMS, text message-based reminders to be sent when it was time to bring that child back in for a vaccination. And in piloting that just over 6 months, we demonstrated an improvement in coverage rates to the 95th percentile. Which is really powerful. And we make it a point to try and do this in an evidence-based, extremely rigorous manner to demonstrate these outcomes. And it's a project now that's scaling. It's gotten $250,000 more in funding to spread it throughout Delhi as well as other urban and peri-urban as well as rural areas. But I think it's a great example of process and how it was really vital to understand what the challenge was and why the status quo was the way it was.
So it's really just breathtaking in scope what you were able to accomplish in such a short amount of time. So the Haiti earthquake was in 2010. You were in India increasing the vaccination rate in 2010 as well, or 11?
So the conception phase started at the end of 2010. I was at Columbia working on a public health degree. And I remember going to Barnes & Noble's on 86th Street every night after studying for whatever it was I had to do for Columbia. I would go to Barnes & Noble's and stay there until they closed, working on the proposals, working through the model, making calls to our partners on the ground in India, and laying the foundation for a trip where we do the final stage of our participatory design to understand the intervention. So yeah, it started in 2010, but we weren't on the ground until the summer of 2011.
When did you start to bring in partners beyond the three of you, actually? At what point did you start to hire people?
We didn't really start fundraising until late 2010, and we didn't start hiring until mid-2011. So we jumped from 5 people to 20 people in the last year and a half. We were 5 people spending a week in each country for years at a time before that.
And you were from the East Coast, but you're living on the West Coast going to Stanford. You were, I've known them for 2 years now. Nadim had graduated, was in medical school, but took a year to go to Columbia University School of Public Health. So they're doing all of this while the backdrop of their lives is other kinds of work. So, why do you think? Where did this come from? This drive, this concern for people globally who had issues with health. I mean, why did you care? What were the influences on you? Can you talk about your early influences, later stage influences?
Yeah, sure. So I'll talk about personally, and then I'll make a comment for our generation. You guys can push back if you want, but I'll start with my personal narrative. So my mother is a physical therapist. She works with students with special needs in the public school system in Northern Virginia. And I really specifically say she was the one that was that led me on the path to be a doctor. She taught me to care for people. And my dad, I grew up in the middle of, he was at the FDA as Kessler's chief of staff. I grew up in the middle of the fight against big tobacco. That 10-year, very long, very high-level, policy-oriented fight. So anyway, it was a mixture of those two for me. I'll say about our generation that global is the default. That the widening of circles of moral concern. Peter Singer talks a lot about the global moral circles expanding. It's basically, here's a map, draw a circle around the people you care about. If you go back a couple hundred years, it's your family and close friends, then maybe your town, then maybe your country with nationalism. We've hit a time where that's a global circle, at least it was for me. So global health was the default going into Stanford. So there's that, and then honestly, Pew does great research on our generation, on millennials, and for the first time they asked us about long-term goals and long-term values, and they asked us to rank things that were important to us. And some of the stuff you might expect was up at the top. So first is to be in a successful relationship, be a good spouse. The second was to be a good parent. And the third, the very next one, was to help those in need. That was above owning a house, having a high-paying job, or being famous. Seems like a tough poll to pull off, but I really like the data they came up with, and I think it represents us well.
I'm in agreement with you about your generation and yours as students here. I think you are the hope of the future. You're the bright lights. That's why I wrote the book. But Nadim, and also I also want to mention that Josh went to Stanford without the plan to do any of this. I mean, he said he went to play soccer, really, right?
Yep.
And then to become a doctor, an MD. But he's not an MD, and he took a different course than he had in his head. Nadim, you want to talk about your family a little bit?
Sure. So I echo everything that you said, Josh. I think that's really spot on. I think my interest in doing this sort of work. I mentioned that my parents both came from Bangladesh. My dad, he's a physician at Geisinger Hospital. It's a really small town in Pennsylvania called Danville. And he and my mother immigrated here in the 70s, in the mid-1970s, and it was really hard for them to get here. They basically left shortly after the war in Bangladesh, the War for Independence, which was in '71. And so they really inculcated in me this sense of privilege, that I was really privileged to be here, and it was in the United States. And I had access to so many opportunities that otherwise wouldn't have been available to me had they not been able to get out of Bangladesh. And so that narrative, or that I guess theme, has been present in my life since I was a kid, and that's what fostered my curiosity to go back to Bangladesh. And I think when you have certain experiences and see certain things, specifically inequities that are just right in front of your face, it's really hard to ignore it. So I told you that anecdote from the cholera treatment facility where I was working, where I saw these patients dying in front of me. And Bangladesh is a place where these inequities between rich and poor are in your face all the time. There's a whole industry where basically crime lords take infants and maim them. They'll make them cripples so that when they grow up they can beg in the streets, and then all that money gets funneled into them. There's some really sick industries in Bangladesh, and when you see things like that, you can't ignore it. You can't ignore it. Josh is talking about this idea of a global conscience, and I think that I don't fully understand it, but I think part of what contributes to this sense of selflessness that I think our generation is uniquely embracing is the social media revolution. I think it's really difficult to ignore or to be kind of a bystander now. It's hard to stay uninformed. We're being barraged with information about what's happening globally all the time. And I think that's giving us an important sense of how different life is in different places and what these inequities are all about. So I think that's kind of what inspires me to do this sort of work. That's what, you were talking about me being in school, and I've never been really full-time with Medic Mobile because I've been in medical school and public health school in tandem with it. But I found the time to do it because it's something I really care about. And I think if you really are motivated by an idea, you find the time somehow. So my biggest motivation is just these experiences, the patients I've seen, just the communities I've interacted with where life is just so unfair. And it's almost like, how can you not try and do something to...
I'm fascinated by these transformative moments in both of their lives where they see a problem and are so deeply affected by it that both of these young men wanted to address it and help solve a huge problem. I know that both of you had later influences on you, and perhaps you could share that. Who else or what situations influenced you beyond the earlier ones?
So I'll start. When I got back to Stanford after that first trip to Malawi, I met a guy living in a van on the edge of campus, literally living out of a van down by the river. So Ken Banks was a genius software developer living in a van and developing open source technology that let you manage lots of text messages. And just crazily, my anthropology professor decided it'd be a good idea for us to meet. So we hung out under a tree at the business school one day. Turned out a match made in heaven, and we used his software. We use this software in 16 countries now. It's one of the core tools that we deploy. So there's that. But honestly, for me, the most important matches were my teammates and anybody building a company. I can see a lot of future company builders out there. So the number one rule is hire people smarter than you, recruit people smarter than you to work with you. And there's a great Steve Jobs quote, and I'm going to get the grades wrong, but the concept is there, that if you're a B+ person, you must bring on an A+ people, because that's the only way to grow in the right direction. And once the great people are on board, the best ideas have to win, otherwise those great people won't stay. So that's team building in a nutshell for me after the last 3 years.
That's great. Those are good quotes from Steve Jobs. And I think Josh definitely had his work cut out for him, being an A+ person himself. I don't know how you managed to find people that were more qualified or intelligent than yourself, but you stole part of my answer, and I'm furious about that. But I'm really inspired by people in our space. I'm inspired by you. I'm inspired. It's not even about age. I'm inspired by what you've done, Jill. People that are just really passionate about what they do. They all have such interesting narratives and unique stories as to how they arrived at their current career path or their current aspirations, and it's always inspirational to listen to it. And that's why I think that your book is so powerful. You really dive down, you delve into the biographies of these stories and what the most salient things were in shaping these personalities. Specific mentors, Josh and I have been really fortunate to be connected to some amazing people. One mentor of ours that I've really connected with is Ronnie Zeiger. He's the former chief strategist at Google Health, and he's on our board now. And there's a message that he encapsulated really well. It's a message that I was trying to refine in my head when I was at Yale, trying to figure out what it was about public service work that I thought was important. And I think I now view it almost as a moral obligation. If you're capable of doing something in the service of humanity, I think you should. And the way he says it, you find the skills that you think you're competent at, and you make them into, you master those skills. You make yourself as efficacious in your perceived skill set as possible. And then you use those skills in service of something greater than yourself. And that's a pretty close quote from him. And I think that that's really stuck with me. And it's what I've tried to embody. It's the reason why I pursued particular paths in public health and learning about stats and trial design and things like this. I've been trying to make myself as effective in my role in the nonprofit as possible.
The two of you, you're going off now to probably the East Coast to become a resident.
Right.
And you're still going to be part of the Medic Mobile team. How do you feel about that?
So I'm not letting him go in any way, shape, or form. And so he might not be our research director because he won't have time for that, but he will forever remain an advisor and a friend. And think that it's really important to note that for us, we get 3 years at a time. That's sort of the average that we spend on any given project or on any given team. It's 3-year chunks. It's for some reason that's how things are going. So instead of the long climb up a career ladder, a 20-year career ladder, what we carry with us are our values, things we've built, and relationships we've built. So that's what's important, I think, and where the strength is for us.
If you close your eyes and imagine yourselves 5 years from now, 10 years from now, have you thought about that?
On Mars. No, I really do look forward to the day that abroad means Mars or somewhere else, because that'll be a great day. Sorry.
Well, there was this class apparently today where the professor is connected to
Yes.
Right.
Curiosity rover. So,
There's a lot of health inequity on Mars too, I hear.
but so you see continuing what you're doing, but as to get it out there as broadly as you possibly can
To say,
into the universe.
in a half sentence, I want Medic Mobile because our mission is to improve lives for communities that are underserved and disconnected. We're a long way from global health equity, so basically I want Medic Mobile to be a platform for people to do their life's work, whether it's a year or 10 years with us, and that's what we're trying to build.
So there are possibilities for Cornell students to intern with you?
Absolutely.
Absolutely. Yeah. We've got a fellowship program now. It's an annual fellowship program. We've been sending fellows for the past 2.5 years to sites all over the world to help us with project design and project implementation. So
And
always looking
Nadim,
for good talent.
Nadim, what about you? Do you also see yourself in staying involved and wanting to extend the reach?
It's never even been a question for me, honestly. I have this career path that is important to me. Residency, I think, is an important part of my understanding of the human health condition. And we've been talking about this kind of all day, back and forth in different interviews. But I was saying that what we do at Medic Mobile is we really impact human lives, and that's our goal. And then that's a mixed blessing, because if you implement something that's really useful, you might save some lives. But if you implement something that isn't as useful or takes resources away from something that might be even more useful, you might have the opposite effect. You might result in some lives lost. And having that understanding of what it means to have a human life in your hands is something that you acquire in a residency, where you are literally the first-line caretaker for a patient. And having that understanding, I think, is really important and humbling. And it's something that I think is going to help me stay grounded in public health work and global health work. But with respect to Medic Mobile, it's never been a question. My role might change, but I always intend to be involved from an advisory standpoint or otherwise. And I don't know what my life is going to be like after residency. I mean, I close my eyes, and 5 years later, I'm still a resident. So may have to project out a little bit longer than that, maybe 15 years down the road. But I'm not that good at imagining.
It's, the future's the future.
Right.
If you, I know, Josh, that I have read and spoken to you about the fact that you get up in the morning and you feel as though every single day requires intentionality, right? So could you sort of share where that comes from, what you mean, how you do it?
Yeah, sure. So it actually started with a note card during the project after the earthquake in Haiti. We were doing things on really crazy time schedules. We were working 23 hours a day, easy, plenty of cups of coffee. And the note card that I had after those quick naps that I would post on the bedpost to wake up to, the question was, what can you do in 24 hours? And that's not sustainable, right? Only in spurts can you act that way. But that sort of set us up, and we all feel that there's an urgency to the work. We all feel that the day that clinic isn't equipped with that software that can help them reach more patients is a day where we just haven't worked fast enough and haven't expanded fast enough, and it's a burden, but it's also a great motivator, honestly.
Absolutely.
So you look back to 1850, and I've been talking about this all day, but if you look back to 1850, there wasn't a country on the planet with life expectancy over 40 years. Life expectancy at birth over 40 years, just back 1850. Now, it wasn't because people were passing away from 39 to 40. It it was because under 5 mortality rates were terrible. And then if you fast forward, we doubled life expectancy globally in less than 100 years. That's an amazing human accomplishment to have done that. But we've landed in a spot where there's mass inequity. And there are now 10 countries where 25% of kids don't make it to age 5, fully a quarter. And so that reality, that 1850 reality still exists. And as long as that's the case, our work is not nearly close to done.
I get it.
Yeah.
Why do you work? I mean, I know the answer actually, but I think it's important to talk about it because I've had questions about it too. Why do you work globally and not in the United States only?
Sure. One distinction we made earlier today, we were talking about how the United States is part of the globe, and your backyard is also a consideration when we talk about global health. And that's important to recognize. I think we started just, there's a lot of reasons. Malawi and Bangladesh are actually easier places to work in than in the United States. There are all sorts of, administrative hurdles and barriers here that, bureaucratic sorts of things that don't exist in the developing world. But I think the most dramatic need is also there. And that's not to diminish some of the need that we see here in the United States, which is also dramatic, especially in select communities. But it's really where our experiences, I think, had initially motivated us to really intervene. And then a lot of it from there was other clinics and other partners in neighboring countries who had heard about us through Josh blogging nonstop that wanted to try out an intervention in their community as well. And so I don't think it was a calculated thing, at least not for me. It wasn't a calculated thing, where we said we want to work in the developing world and be that kind of organization. And I think what makes that true is that we now do work in the United States, and we've tried to bring back a lot of the lessons that we've learned implementing in Africa and South Asia and Haiti, around the world, and try and bring back those lessons to create really cost-effective programs here. We have 2 projects in California now where we're sending reminders to diabetic patients either to follow up at an appointment or to facilitate glucose checks and facilitate calculations for how much insulin they need to dose themselves with. And those are innovative ideas that came from the developing world that we're now trying to bring to bear here in the States. So that's the answer.
I'll
Go
jump
ahead,
in
no,
just
you go.
really quickly.
Yeah, don't be quick.
A philosopher I'd quote right off the bat here is Rawls, and the veil of ignorance. And really simply, I don't feel that I morally deserve the conditions at the start. Basically, I could have very easily been born into I think the cosmic dice are rolled. I'm born in rural India, or in Dhaka, or in Nairobi, or in Loudoun County, Virginia. You don't morally deserve the starting conditions, and so we need to imagine and create a world where those starting conditions don't matter to essential services and things like healthcare. It's just that it's not acceptable.
The birth lottery.
Birth lottery, yep.
We all want it, right? I wanted to tell the students here that over the past years of doing this program, some students have come and returned year after year. And a few years ago when Jacqueline Novogratz spoke, I think I told you guys this, a student came up to me who had attended 2 of the lectures, and she said, Jill, I'm going to law school next year. I can't, and also I don't think I can read to the kids in the slums of Nairobi. So what do I do? And at that point I said to her, well, I'm not reading to the kids in the slums of Nairobi, and not everybody has to do what Josh and Nadim are doing, that there's a role for everybody to play. And I'm wondering if you can think about that for a minute and have examples, perhaps in your own lives, of people who are making a contribution, but aren't necessarily treating cholera victims in Bangladesh.
Yeah, I'll start. So right off the bat, what I want to say is that there's a relatively small capital pool and relatively small job growth just at the outset for groups like Medic Mobile. I mean, we're going to double in our team size, so that's just 20 more jobs. And I'd love to hire anybody who's drawn to our mission. We're just not there. We're not quite there yet. And we're not IBM. So at some point, I hope that the social sector does grow like that. But even Teach for America, it's insanely selective. It's a fantastic program. So instead, the jobs people will find are at Coca-Cola and IBM
Still.
and Apple. Still, that's where jobs where you're likely to work. But it doesn't mean that you can't. If you're teaching at a public school, it's for America, or you bring it with you. It doesn't have to be part of this explicit program. It's a value set. It's a commitment to equity, and that's what you take with you wherever you end up working.
Yeah, I agree with that. Just to give, maybe we can turn this into a plug for Hope Phones, actually. There are so many ways to get yourself involved in something, and it doesn't really matter what that specific thing is. And I'm just going to re-quote myself from Ronnie Zeiger, identifying what you're good at and using that to serve humanity in some way, I think is a good motto to live by. With respect to Medic Mobile, we've tried to create outlets for anyone to get involved in a limited capacity. And one thing that we've created is something called Hope Phones. There are about 250,000 phones that are turned over every day in the United States. And you can send them to us, and we basically repurpose them for use in the developing world, or for our projects, wherever they might be. We put phones in the hands of healthcare workers, sometimes in the hands of patients, to promote our work and to provide the infrastructure necessary to implement our projects. Hopephones.org is the site. It's a national campaign. You can print a shipping label out and basically drop an old phone that's collecting dust in a drawer into an envelope and send it to us. You can start collection campaigns at your university. We've already had some interest from students here today talking about it. And we've been trying to make this a viral sort of thing. So that's an example of a really small thing that anyone here can do. Because I'm sure 95% of you have an old phone, maybe 100%, I don't know, sitting around somewhere, and we can repurpose it. We can refurbish it and put it to good use. Yeah, so I think even really small contributions can make a meaningful difference. But you have to have, like Josh was alluding to, that kind of mentality and that perspective about giving back.
Well, I think that's a great note to end on, and I could talk to you guys, I was like forever. And I hope that you can all see why I feel so blessed to be working with people like Josh and Nadim, who are making such an extraordinary contribution to changing the world. So I thank you both so very much.
Thank you so much. We could talk a lot about of your work and get into the nitty-gritty. I'm sure we have lots of questions from people in the audience, so we want to leave the next 10 minutes for questions. So I think there's a microphone somewhere. Pedro has a microphone, and there's one over here. So we have 2 microphones. How about some questions for our guests? Right here.
And just a quick plug, you can tweet me at Josh Nesbit or at Medic, and we'll get back to you later once we're back to Wi-Fi at the hotel. So if we don't get to questions here, ping us later.
Yeah. And my handle is just at my first name and my last name.
Okay, so I kind of have some things to bounce off of, not really a question, but...
Can we make sure we have a question in there?
Okay, yeah. So obviously there's a problem with like the brain drain of physicians coming from developing countries because working conditions are not what are desirable. So they're coming here, and we're seeing problems with basic things going untreated. Like you were saying, there's one doctor to 250,000 people in Malawi. And so I guess what my question is for you guys is, you're setting up these clinics in response to issues like the cholera outbreak, and I was just kind of wondering where these clinics are coming from, who's working them, and also if you're doing any work to help with the infrastructure of medical systems and maybe prevention instead of just treating the issues, and also if there's any, I know you're doing a lot with cell phones, but telemedicine is becoming a big thing now, and I know there's a lot of like FaceTime ability that's becoming present in the United States. And just kind of wondering if you ever see that playing a role in what you're doing now.
Yes, sir.
Yeah, so I'm going to do my best. I think there were 4 questions. I'll give you a sentence each. So first, health system strengthening is critical. I sit on the board of a really amazing organization called IntraHealth International, focused on training health workers, getting more doctors trained and supported. But I was hanging out with the Minister of Health for Liberia last week, and he made a brilliant comment that we need to redefine who a health worker is. That a health worker is anybody in a group of people working together to solve a problem. That includes the mother of a child who's bringing that kid into the clinic. It includes the community health worker who's accompanying them. It's a redefining of the health worker and who we need to support in the systems. On the telemedicine side, it's something we're really excited about. Our colleagues at UCLA figured out how to hack a $15 camera phone add-on to do intracellular blood imaging. So you slide a blood sample onto the back of the camera phone, shine an LED on that blood sample, you create a holographic image that then is sent by picture message, and it returns a diagnosis for HIV, TB, and malaria. So these are the types of things that are coming, and that's what the next 5 years looks like.
Yeah. And just to tack on very quickly to that was a perfect response, Josh. About telemedicine and kind of building the infrastructure, we're working in very limited resource settings, like you mentioned. They are understaffed, they're under-resourced, they're underfunded. But what we're seeing is that by providing these mobile health interventions, and telemedicine is a great example as well, where it's changing the role of what the health worker can actually do. So a health worker, a community health worker, empirically they've been charged with providing limited curative care, sometimes escorting patients to and from clinics, trying to provide emergency triage and things like this. But none of them are really formally trained in laboratory science or medicine to any significant extent. But what you were describing is an example, that telemedicine innovation where we can actually do diagnosis using a camera phone. We can train a health worker to collect a blood sample and snap a photo of that slide, and they can send that via MMS or picture message back to a system that automatically reads it, does a complete cell count for you, can tell if there's parasitaemia or bacteremia, diagnose malaria, and return an SMS to that health worker who now has the capability to do that diagnosis themselves.
Okay, so,
Over here? Oh, right here?
so given your backgrounds and your recent work in the U.S., what do you see being the biggest upcoming health crisis for America? And what could we be doing about that as your work's overseas here at home?
You say health crisis?
Or upcoming health issues in America?
So the question is, what do you see as the biggest upcoming health issues or crises?
Yeah, there's so many issues with the health system here. It's really hard to get into it all, but if I had to pick one issue, it's cost containment. The cost of healthcare here is astronomical. We spend more per capita GDP on healthcare than any other developed country, or basically any country in the world, and we don't have the best outcomes. In fact, we're like 16th in terms of life expectancy or something to that effect. So we're spending a lot. It's extremely expensive. It's multifactorial on both the supply and the demand side. How can mHealth be brought to bear on that? I was alluding to some of the projects that we're doing in the Bay Area now, where lessons we've learned working in the developing world, something as simple as sending out an appointment reminder via text. Here, that doesn't really happen very often. If you have an appointment coming up, do you get a text message? And just a simple intervention like that, which is super cost effective, is a preventative health measure. It's a way of engaging someone more fervently in their own healthcare. And I think we're going to see, hopefully, these innovations that are super cost effective being piloted abroad, hopefully coming back here to the United States as a means of being both efficacious and a cost containing measure. It's kind of a really quick answer for you.
Over here?
So how did you guys acquire the funding for this organization?
Yeah,
Could you repeat that?
I think the question was about how we get
How
funded.
do you acquire funding?
Oh,
Yep.
Sure.
So we're funded half with pure philanthropy, people who believe in our mission. People want to see us build useful products for health workers and patients. That's half philanthropy, and then half to get a project up and running in a specific country for a specific thing.
share its CGI story last Clinton Global Initiative.
So CGI is an amazing meeting. I would really encourage you to intern, try to get in to volunteer, and to work there and run projects, pitch to CGIU, and work your way into that pipeline. President Clinton invited us, and the Minister of Health from Liberia flew from Liberia to join us on stage last week to accept an announcement from President Clinton. We have a really ambitious project in Liberia where there's no health service being provided. There's also no mobile phone coverage whatsoever. So our pitch was we're actually going to stand up our own cell tower and provide our own coverage out 30 kilometers from the hospital in each direction. We're going to use our own SIM cards. It'll be free for the entire community. So it was a really ambitious project. We raised $350,000 in 24 hours at CGI just by talking about this initiative because of the people in the room. So sometimes you have to go into a meeting very confident that people are going to resonate with your project's idea.
True.
Here's the question right here.
Thank you, Professor. As students at top-tier institutions, how do you find the balance between school and work? Because I can tell that it's very time-consuming, and I'm sort of in the same position where I'm trying to work with an organization to tackle a university problem, but at the same time be a straight-A student.
Oh, man.
We're going to get different answers. So
Very different answers. Yeah, that's a really good question. It's been extremely challenging for me. Like I said, I never really took off dedicated time to be full-time with medics, so I've been balancing medical school, which is more than a full-time job as it is. I guess two things I can say about it. My schedule as a first-year medical student, you're in class essentially 8 to 5, and then you eat for 30 minutes, or eat while you study, and then 5:30 to 10, you're just working on the lecture material and studying. And then 10 to 3 became the time that I was committing to Medic Mobile, working on venture plans and business models and trying to figure out the process of innovation. And I don't know where that energy came from, to be honest, initially. I think I can say now I know what sustains it, and it's seeing the fruits of that labor actually paying off. Initially, we hit a lot of walls, and we were stumbling constantly. We were literally face planting every time we were giving a pitch or trying to raise funding. But the first time we got funded, and the first time that we had positive results from a study, it was all of a sudden everything was validated. I mean, I feel like I have endless amounts of energy to give to this project because I so actively believe in the mission. So I guess I would just say that if you really believe in what you're doing, you just somehow find a way to make time for it.
My short answer is that there really wasn't a balance. That I went with what I was most passionate about. I passed quizzes and tests and stuff. I turned in a really terrible honors thesis. It was the worst 100 pages of writing anyone's ever had to read. And my thesis advisors knew that we were launching a company. And so, they didn't give me a pass, but it was just acceptable. And I graduated early to get on with it and co-found Medic. So yeah, for me, I've never been asked for my GPA. I've never gone back and said I took this course and not that course. It was the people that I met, the ethos and pathos and logos of the institution that's been most important.
Note from the professor, don't count on that.
We're running a little over time, so I think we're going to have to make this the last question over here.
How do you find and define and refine new projects? Do you have a pipeline of people in the developing world and partners? How do you come up with new things, basically?
So sometimes it's CNN covers us for no good reason, and a doctor in the middle of Ghana Skypes us at 2 a.m., and we have to click accept, right? So it's those types of really organic things. But mostly we know that USAID wants to invest $40 million to strengthen health systems in Senegal, and we know there are 5 or 10 fantastic local NGOs working at the grassroots. So we've become more proactive, and we're setting up regional offices in Nairobi, Dakar, Dhaka, and Delhi to build the right relationships with the right people to get the work out at scale. So we grew really intensely by poll, and now we're opinionated about how we can improve health systems, and so we're working with people who can help us get that work done.
Yeah.
Well, I want to thank you all for coming. I want to thank Josh and Nadim and Jill. Thank you.
Thank you so much.